Yep. So hi everyone. Thank you so much for signing up to our seminar today with Dr. Ashwani Garg. He's our host on the topic of calculating impairment using AMA5 guidelines, the psychiatrist edition today. So during the seminar, just to show respect to the presenter, we'd kindly ask if the attendees could please just mute themselves. And if anyone has any questions during the presentation, please feel free just to pop them in the chat box below and we will attend to it at the end of the presentation. We'll have a little Q&A session there. And please note that this session will be recorded and published on our YouTube channel. So if you have any issues with this, please do let us know immediately. Just a brief introduction about Dr. Ashwani Garg. He is a consultant psychiatrist with more than 15 years of experience working with clients with mental health issues. He has been a fellow of the Royal Australian and New Zealand College of Psychiatrists since 2010. He is also a fellow of the American College of Independent Medical Examiners. Currently, Dr. Garg is the director of the Bremmer Specialist Centre. He has many years of experience in medical legal assessments and provides concise reports that showcase his empathy for the client. Dr. Garg presently consults in Brisbane and is available for video exams across all Australia. So over to you, Dr. Garg.
Thank you, Sophia. I will share my slides. Sophia, can you see my slides?
Yes, I can. If you could go back to slide 1. Yeah, perfect.
Okay. Thank you for a nice introduction, and thank you for inviting me to talk about this topic. It is a very special topic at present for me. I have done more than 1,000 reports, and I've noticed some very, very interesting things while doing these reports. So I would gladly like to share my experience in doing PIS rating. So let's go to the topic first, AMA5 and how psychiatric impairment is calculated in AMA5. So basically in AMA5, there are 4 domains, and they look into activities of daily living. They look into social functioning of claimant. They also look into concentration and adaptation. And then they rate their functioning on 5 classes. So class 1 is no impairment, class 2 is mild impairment, and mild impairment means there's some useful functioning in most areas. Class 3 is moderate impairment, where there is, in mild impairment, there's useful functioning in most areas. In moderate impairment, there's some useful functioning. And in marked impairment, there's significant impairment in useful functioning, and extreme impairment is no functioning. Now, you don't need to worry about all this because unfortunately, AMA5 psychiatric impairment does not give you a percentage, does not give you whole person impairment. And the reason for that is the psychiatrists who are involved in writing this chapter could not come to an agreement. And there are very valid reasons why they could not come for agreement. And that's what I want to talk today in my presentation. So what we do in Australia is we use a rating scale called PIRS. It's called Psychiatric Impairment Rating Scale. So all the states in Australia have their own guidelines. And if you read their mental health chapter, it will say that the AMA5 chapter of mental and behavioral disorder is replaced by guidelines on psychiatric impairment rating scale. So that's how we do psychiatric impairment in Australia using PIRS rating scale. And that's what I'm going to go in detail now. So there are some general principles when you're doing a PIS rating or permanent rating, impairment rating. So you have to assess client as they present on the day of assessment. And also include all the relevant medical information, whatever you have, and then you try to answer a few questions. So the first question is whether the person you're seeing has a compensable injury and that injury has resulted in an impairment. So if somebody has developed depression after a workplace incident, but they have fully recovered from depression and they do not have any impairment, then they cannot be rated basically, or they will have zero impairment if you rate them. So the first thing is to determine whether this person has developed a psychiatric condition and also that condition is causing some impairment, which you can rate. The second thing is when you are doing the rating, the condition has to be stable and stationary. So basically, the compensation is only done for a permanent impairment. So if somebody has developed depression and they are having impairment, but they improve, they do not get any permanent impairment. So the condition has to be fully treated and stable and stationary when you're doing the assessment. If somebody is having fluctuation of symptoms on day-to-day basis, or their condition is getting worse or improving, that is not a time when you can do the assessment. And the condition has to be fully treated, stable and stationary. Then only you can do the statement, impairment rating. So the third question is whether the resultant impairment is permanent. That means, as I said, the condition has to be fully treated, stable, stationary, and the impairment is not likely to change. Then you can say, yes, it is a permanent impairment. And once you have established these facts, then you do the impairment rating based on a scale, and then you calculate the degree of impairment based on some calculation which we'll go through. And once you've done that rating of the current impairment, then you do assessment of the pre-existing impairment in the same way, and you subtract pre-existing impairment from the current impairment. And that gives you the final impairment. So the stable and stationary has been a very interesting thing which I have observed. And people have different ways of assessing it. Most of the psychotic condition, they take long time to settle down. But somehow what I've noticed is because the work cover finishes by 2 years, by the end of 2 years, everybody starts sort of hurrying up things. Now they're going to finish. We need to just do the MAT assessment. Can you say a condition is stable and stationary? And most of the psychiatrists by that point will say, yeah, condition is stable and stationary. In the civil cases, it's 12 months. So most of the legal practitioner will approach you once 12 months has occurred after the incident, then they will say, can you do the PIS rating? And most of the psychiatrists will say, but it really sort of is a very, very variable. It depends on what condition claimant is suffering, what is the natural course of that illness, and how long does it take for people to recover, the treatment. So it is a very critical decision, but it is often not taken very seriously, and you will see a lot of differences when you are seeing the report that some people get assessment bit early, and if you are doing assessment bit early, then you are going to get more impairment than you should. And if you're doing assessment very late, then you're going to get much less assessment. So it really affects impairment rating a lot. And as I said, that there are some stereotypes and some practices going around, and that's what most of the time happens. So basically, when you are saying stable and stationary, you have to sort of make a guess that permanent impairment is unlikely to improve further. And that's when you say stable stationary. If someone has not received adequate treatment and maximum medical improvement has not been achieved, you should not do the permanent impairment rating at the time, and you should differ, and you should say, look, the person is not fully treated, they need further treatment, and I will do assessment rating after 6 months once they have completed the treatment. Um, and you should not do. So it usually happens sometimes people come to see you and they've just started a new medication, or they've just started seeing a psychologist. So at that point, you do not know how they're going to respond to medication, how they're going to respond to psychotherapy. So you cannot say that person has reached to maximum medical improvement, and you should defer your assessment and wait for them to complete the treatment. So the other thing, you need to do the adjustment for the effect of treatment. So some people have improved with the treatment and their impairment has become less, but they are having some adverse effects of medications. So they are having dry mouth, or they're very sedated, or uh, so all those things you have to assess based on that chapter. So if somebody is having dry mouth, you have to go to gastrointestinal system and rate that side effects and add that impairment rating to your final impairment. Sometimes when people have taken the treatment, they have a very good improvement, and there is a substantial or even total elimination of permanent impairment. But these people should not be given zero impairment. They should be given some impairment, because they're going to take medications for long time, and it's not fair for them to keep taking medication and not have any sort of compensation for that. So in the most of the state guides, you are allowed to give 1 to 3% uh, for treatment effect, but it's only to be given if there is a substantial or total elimination of permanent impairment, and the permanent impairment is likely to come back if they stop taking their medication. So if they fulfill these two conditions, then you can give them between 1 to 3%, depending on how much um, treatment is, what is the effectiveness of treatment. So in case of total elimination, you will give 3%. In case of sort of substantial, you might give 1 or 2%. If somebody is refusing to have treatment, which is perfectly fine, and a lot of people do not want to have psychiatric treatment, or they had psychiatric treatment in the past and they had bad side effects and they don't want to have it, or they have heard bad stories about it. So these people should not be rated less. So they should be rated as their impairment is, and just refusal to treatment should not have any effect on your permanent rating. So the medications we use in psychiatry are often not very effective, and they do have very unpleasant side effects. So it is fair for people to refuse to take them. Um, so, so when you are doing a evaluation, you do evaluation of current condition without considering that if they have treatment, how much impairment will decrease. That should not be considered. And you should note the reason for refusal in your report, and you do not adjust impairment on the basis of whatever reason they are saying. So similarly, if there is a future possibility of future deterioration, so there are some psychotic conditions like recurrent depressive disorder. So someone might be doing fine, but after 2 years, 3 years, something may happen in their life, and they may have another episode, and their functioning may decrease. You cannot rate that future impairment now. So the rating has to be done based on the current functioning. The future deterioration is not considered when you're doing PIS rating. Uh, so Usually, the psychiatric impairment in work cover cases is done, assessment is done by medical assessment tribunal, where 3 psychiatrists sit and they do the functional impairment rating scale and they give the final impairment. In Queensland, there is no difference between primary or secondary psychological injury. So primary injury means somebody had workplace bullying and has developed depression. Secondary means somebody has a motor vehicle accident, they have lost their leg and now they can't work. And because they have lost their work capacity, they have developed depression. So this is a secondary injury. So in Queensland, both the injuries are rated same, whether it's primary or secondary. But in some states, secondary injury is not identified. So you just need to follow your state guidelines. So the impairment rating must be based on psychiatric diagnosis. So basically, person should have a psychiatric condition, and then only you can rate their psychiatric impairment. If they don't have a psychiatric diagnosis which is caused by the incident, then you cannot rate them. Somatoform disorders are excluded from most guidelines. So somatoform disorders are the disorders where people are having symptoms which cannot be understood based on the incident or based on their um, uh, sort of clinical signs or investigations. So if somebody is having too much of pain in the area where they should have, that's sort of somatoform disorder, and these disorders are not rated. Um, so if somebody is suffering from these disorders, they cannot be given a permanent impairment. So pain can also cause psychological problems. Pain can cause a lot of distress and anxiety, but that should be rated in the pain chapter, not as a separate psychiatric condition. So when you're doing the pain rating, there is a domain for psychiatric distress, and if person has, they get extra impairment in the pain. So, so whenever you are doing an impairment rating, you should provide a rationale why you have given that particular rating. Diagnosis is considered, but it's not the only thing. So the PIS rating scale is based on functioning. So like if you have mild depression, moderate depression, or severe depression, it will not have any impact on the rating. But if you are functioning well or not will have impact on the rating. So there is sort of good or bad things about it. So like some people have severe depression, but they have children and they have to work. Unfortunately, those people will not get good compensation because they are functioning fine, even though they have severe depression. And the advantage of sort of rating on functioning is the psychiatric symptoms are experienced differently. Some people react too much to small problems, and some people do not react to a big problem. So that does not affect your rating. You are rating based on their functioning, day-to-day functioning, and how is their work capacity rather than how is their subjective experience and how they are reacting to a psychiatric condition. So when you are doing the assessment, you get information directly from the injured person and listen to their own description of their functioning. And then you also collaborate that information from other family members if they are available, the medical reports which are given to you, feedback from treating professionals. Sometimes people have psychometric testings, and sometimes they have OT assessment. So you consider all the assessment which is there in front of you, and then you see the functioning over a period of time. rather than just cross-sectionally how they're functioning today. You see how they have been functioning over last few weeks, few months, and based on that, you decide a particular rating. So pre-existing impairment is calculated in exactly same way as the current impairment. Um, and you go through sort of different areas, which we'll go through in detail now. And then you subtract the pre-existing impairment from the current rating. If you are not able to assess pre-existing impairment, so some people have very, very complex psychiatric history. They have been unwell for years and years. Some people are not able to give good history. Some people are not reliable because this is one area where people have a very poor memory of their past conditions. So I often see people who tell, oh, they never had a problem, and then I pull their notes and then say, oh, in 1996 you went to see a GP and you are having this problem. So this is something which is often difficult to assess, and collateral history or contemporary notes of general practitioners are very, very helpful. If you are not able to assess pre-existing impairment correctly, then you can use the 1/10 rule. So you just decrease 1/10 of the current impairment from the current rating, and that's fairly acceptable. Some psychiatrists use that as a blanket rule, like they do not trust patient and they just reduce 1/10 of the assessment. That is not a good practice because it can give you inaccurate rating. It is not very difficult to assess the functioning pre-existing. So it's difficult to assess the whole history, but all we need to know is pre-existing functioning, that how was person's self-care before the incident and how is it after the incident. And if you can do that pre and post, you can get a fair idea of pre-existing functioning. So coming to the PIRS as such, so we are focusing on the behavioral consequences of psychiatric disorder, basically the effect on functioning of psychiatric symptoms. So we are not looking at the psychiatric symptoms as such. So we look into the 6 domains of functioning. So first one is self-care and personal hygiene. Second one is social and recreational activities. Third one is travel. Fourth is social functioning or relationships. Fifth is concentration, persistence, pace. And sixth is their employability or adaptation. And we'll go in detail of all of these domains. So each domain has 5 class descriptors from 1 to 5. And you just choose which descriptor fits best to that person. You also need to take in account of person's cultural background, their age, and their sex, because there are different people have different norms. And but all you're trying to do is compare pre and post. So if you are comparing how this person was functioning before the incident and after, it sort of nullifies all the cultural factors, age factors, sex factors. So it sort of takes care of that. So let's go through first domain, self-care and personal hygiene. So there are 5 classes. Class 1 is no impairment and class 5 is totally impaired. Most of the time you see people who are class 2 or class 3. So class 2 is mild impairment. So in this domain, people can look fine. They may look after themselves adequately, but sometimes they may look unkempt. And sometimes they may miss their meal. Sometimes they may rely on takeaways. So this is often not interpreted correctly. Some psychiatrists, they just look at a person, oh, you look fine, do you shower, and they just say, oh, no impairment at all. While these people may have some impairment. So all you need to do is compare their pre-existing functioning, and you ask them how often you used to shower, and they'll say, well, I wish you shower every day. How often you shower now? Now some days I don't feel like having shower. How often you used to cook meal before? Or we used to cook meal 3-4 times in a week. And how often you cook meal now? Now I don't feel like cooking meal. I often get takeaways. And that's good enough to give a mild impairment. In class 3, this is more clear, class 3, so there's no ambiguity here. So the person cannot live independently without regular support. So they need someone to prompt them to have shower, someone to prepare their meals. And if that is the case, then you give them class 3. And class 4, people are living in residential care. They need constant supervision. And if they are not supervised, they may hurt themselves or they may get into trouble. And then you give them class 4. And class 5 is totally impaired when they need assistance for basic functions like feeding and toileting. Then you give them class 5. So second category is social and recreational activities. So this is pretty clear. People will tell you, oh, we used to enjoy socializing with people, calling people home, but after the incident, we don't feel like do that, or we go sometimes out, but we don't enjoy as much as we used to enjoy. And that's sort of, if they are still able to do some recreation activities, but they're not able to enjoy as much as they used to enjoy before, you give them class 1, class 2, which is a mild impairment. But if someone is rarely going out and they've stopped engaging in most of the activities, or when they go out, they need a support person, that's when we say it is class 3 impairment. Class 4 is the person is not able to leave their residence. They are mostly confined to the resident, and they can tolerate their family members, but they can't tolerate other people. So class 5 is totally impairment. They cannot live by themselves. They are extremely uncomfortable if somebody comes to visit them, even if they are a close family member. So next category is travel. So travel is a category where there's often errors in interpreting the criteria. And the criteria itself is not very well written. So there is some confusion, and a lot of people sort of do not get impairment in this domain. So class 1 is no deficit. Basically, person can drive and go to different places. Class 2 is mild impairment, where person can go by themselves without any support, but only to familiar areas like local shops, or they can visit a neighbor. Unfortunately, there's a lot of people who have psychiatric conditions, but they have to work as a tradie and they have to go to different places and new places, and they push themselves. They had a motor vehicle accident, they have developed PTSD. Every time other car comes close to them, they have anxiety attack, but they push through it. So unfortunately, as per these guidelines, they sometimes do not get any impairment because they are able to drive, even though they're having a lot of distress. But they should get some impairment. They should get at least mild impairment. So this is sort of often interpreted differently by different psychiatrists. Class 3 is pretty okay, and it's usually rated correctly when person cannot travel away from their own resident without a support person. Whenever they go out, they need a person with them. Class 4 is they feel extremely uncomfortable if they have to leave their residence, even with a trusted person. And class 5 is totally impaired. They may require 2 or more person to supervise them when they are traveling. So next domain is social functioning. So this is pretty well written. It's very clear. It's usually rated correctly by most psychiatrists. So class 1 is no impairment. Class 2 is mild impairment when the existing relationship is strained, but people are still living together. Class 3 is there's a period of separation. and domestic violence. And class 4 is when relationship is ended and they no longer live together. And class 5 is when a person is not able to live in society. They are living away from populated areas. They're actively avoiding social contacts. So it's fairly easy. You ask, how was your relationship before the incident, and how's your relationship now? And they will say, well, now we have more arguments, more disagreement. Then you give them class 2. If they say they have been having period separation, class 3. If their relationship ended, class 4. And class 5 is, you rarely see this, but sometimes you see people who are totally not comfortable with anyone. Concentration, persistent pace. This is also sort of sometimes not rated correctly, and especially the mild impairment. So class 1 is no deficit, class 2 is mild impairment when person can concentrate up to 30 minutes. They can do the basic training courses, but they get very tired after doing that and their pace is very slow. Uh, Class 3 is when the impairment is uh, more than mild and they are not able to read even a news article. They find difficult to follow the complex instruction, like they can't read operating manual. They can't put a table together if they bought it from IKEA. They can't read building plans. So that's moderate impairment. Class 4 is very severe impairment when even in your assessment you can see person not being able to follow and understand what you're saying, and they're asking you to repeat your questions, and you can see they're having lapses of concentration in front of you. Then we call it class 4. And class 5 is totally impaired. They need supervision and assistance in institutional settings. So the mild impairment is sometimes assessed by some psychiatrists. Oh, the person can concentrate in the interview and they look fine and they're able to do their job. That means they don't have any impairment. But if you ask them, they will say, well, they are struggling. They are not as efficient in their work as they were before. And then you should give them mild impairment. The last one is employability. So employability is fairly easy if person is working. So if person is working in the same job which they were doing before, then there's no impairment. If it is they're working in this different job, but they're still working full time, but they're doing less responsibilities or they're doing less stressful job, and then you give them class 2. And if they're working less than 20 hours in a different job or same position, then you give them class 3. If they are working uh, only 1 or 2 days at a time and less than 20 hours per fortnight, like 10 hours a week, then you give them class 4. And if they cannot work at all, then class 5. This becomes very difficult if someone is not working because of their physical injuries. And then you are left to do guesswork, whether they can, how many hours they can work. And it's sort of, it is rated very differently by different psychiatrists often. And you'll see difference in rating. Some people will say class 2, some people say class 3. But you have to look into the reasons why they are saying is class 2 or why they're saying is class 3. And based on that reason, you can sort of understand whether it's justifiable or not. So once you have done these classes, then you do some calculations. And first thing you do is you find the median class. So median class is the middle class. And the reason why we try to find median class is because people can have very high impairment in one domain, um, and but other domain may be fine. So if you look into the middle, then you get a fair idea where this person sits across all the um, domains. So how you calculate median class? You look into example A, where person have two threes in the middle, then we say it's 3. If someone has 2, 1, 2, 1, 3, then we say 2.5 and we round it up to 3. Or if somebody has 3 and 5, then we say 4. So basically, you're trying to pick up the middle number. And as I said, the advantage of this is it is not influenced by extremes, and this is a fair way to translate impairment in different domains on a linear scale. Okay, so but each class, they represent a range of the impairment. So the class 1 is 0 to 3%, class 1 is 4 to 10%, and so on. So we still don't know where this particular person sits in that range. So to figure out where this person sits in that range, we do aggregate score. So what we do is we add all the numbers. So if you look into the example, the person has 1, 2, 3, 4, 5, right? And we add all those numbers and we get the aggregate total, which is 18 in this case. So median class is 3, which is on the top row, and in the bottom row is their aggregate score. And then we use this aggregate score on a conversion table. So the conversion table tells us where this person. So the example is the median class here is 3, and this aggregate score is 18. So if you look into this table on 18 class 3, the impairment is 22%. However, if this person has same aggregate score 18, but his median is class 2, then he will have impairment rating of 10. So what it tells us, if the person has a median impairment of class 2, that means this person is less impaired, even though they have same rating. The rating aggregate score is different because one class person has very high score. So that's how it sort of helps us to give a fair impairment rating, calculating a median class and aggregate score. Both helps to get the rating correct. So as I told you in the beginning, I have noted a very different PIS rating by different psychiatrists over a period of time. And there are some interesting reasons which I found. And the first reason I found is there's a different interpretation of PIS criteria. So some psychiatrists regularly say, well, you have driven to my office, that means you have no impairment, even though person is having, anxiety attacks when they came to office. Similarly with self-care, and some people just say, oh, you look fine, you're having shower, you have reasonable self-hygiene, so no impairment. They do not read the criteria correctly and they interpret it in their own way. And that sort of leads to sometimes different ratings by different psychiatrists. Interestingly, I also find that some people do inadequate assessment. So I will give you a real case. This young woman had an accident. It was a minor accident. She was rear-ended in school car park, but she developed full-blown symptoms of PTSD. And the psychiatrist said, well, she had a minor accident, so no PTSD. But when I took the history, I found that she had a major accident on a highway when she was driving at the speed of 90, and there was a head-on collision. And after that, she developed full-blown PTSD. And this accident was only the trigger, the second accident. But interestingly, the whole thing was ignored, even though I have done the report first and the psychiatrists have read my report. but he did not acknowledge that. And the worst was, I have noted all the symptoms of depression, including suicidal ideas in my report, but he said person does not have depression because the person did not look depressed. So if you look into diagnostic criteria of DSM-5 or any diagnostic criteria, the how person looks is not included in diagnostic criteria, because people can present fine, they can hide their emotions, and they may look fine on the day of assessment. The way you assess depression is assessing their longitudinal mood, assessing their activities over a period of time, assessing their sleep, assessing their thoughts. Um, but despite of, being all that information in front of that person ignored that and said, there's no depression. So I did see that person again, thinking maybe I am wrong. And the person told me that it was only, half an hour interview. And they just asked, are you fine, 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 and that's it. So it happens, and I'm not, it happens quite often, but it happens due to some bias, and this bias is not conscious, it's unconscious bias. So sometimes you will see that. I have seen the number of that. I've done a number of supplementary reports, and but that sometimes lead to different PRS rating. Sometimes claimants change their story. So I saw this woman who had a tribunal, and after the tribunal, she read the report, and then she realized that she didn't answer the question correctly. And she told me when I was seeing her for her civil case that she was having problem in relationship, but at that time she did not understand tribunal's question, and she said no, her relationship was fine, but she did not know the PRS criteria and how it works. So people can change their story and for valid reasons, and that can lead to different assessments. Some of the psychiatric conditions have a fluctuating course. So some days may be bad, and you may be doing assessment on a bad day. So you have to be mindful, and you have to see the longitudinal picture, not how that person is presenting on that day. I saw a person who had a panic attack just before seeing me, and she looked really bad, and I gave her very high rating. And then other sites saw that person and gave very low rating. And then I saw that person again, and then I realized what went wrong in the assessment. So you have to be mindful of these things. Sometimes there's a big gap in the assessment time. So like you're seeing someone 1 year after the assessment or 2 years after assessment, and things change, people change, their circumstances change, and they may have a very different rating at the time when you're doing them after a big gap. All right, so that was all I needed to tell you. So I received some questions in email. Someone has asked me about sleep study assessment impact on PIRS criteria and the final assessment. So sleep disorders are rated under a different chapter in AMA5, and they are not necessarily the psychiatric problems. So you have to follow that. And if somebody is having any psychiatric impairment because of sleep problems, that should not be rated in PIRS. So sleep can be disturbed in some psychiatric conditions, and that is part of the psychiatric condition. But if somebody is having a sleep disorder, like sleep apnea, it is not a psychiatric condition. It should not be rated on PIRS. And the second question I was sent the effect of treatment, which we have spoken, that if somebody is having a substantial improvement, then we can add 1 to 3%. And somebody is just having the treatment and they have not reached to maximum medical improvement, we should not do the assessment. If somebody is having adverse effects from medications, that should be rated separately depending on the side effects, which part of the body it is affecting, and you rate it under that chapter of AMA.
Thank you so much, Dr. Garg, for your very informative and thorough presentation. I think it's super helpful, especially to our clients, just to refresh the information of AMA5 guidelines for psychiatrists. So yeah, if anyone has any questions right now, you could just unmute yourself and come forward because we didn't have any in the chat box, but I've already sent through like 2 of those questions to you prior to the seminar. So if no one has any question, we could end the presentation here. So thank you so much, Dr. Garg.
Thank you, Sophia.
Thank you. Thank you everyone for joining. Thank you.
Bye-bye.
Bye.